All right, thank you very much for inviting me to discuss managing common comorbidities and heart failure with a focus on diabetes, chronic kidney disease, and atrial fibrillation. I have no disclosures related to this talk. No financial conflicts of interest, but my one disclosure is that it's impossible to talk about all three of these comorbidities in 15 minutes. So I will just highlight some clinical pearls and approaches for each of these three conditions. So we'll start with a case. So it's a pretty typical case you might see. 72-year-old males being seen, quote unquote, for routine follow-up these days. Often that's occurring by telephone, at least 50% of the time it seems. The patient's known for heart failure, reduced ejection fraction secondary to a late presenting anterior infarction back in 2010 with an ejection fraction of 28%. The patient also has diabetes type 2 for the last 10 years without complications. And finally, the patient, of course, has chronic kidney disease and persistent atrial fibrillation. And in fact, this is a real case, and it didn't take long to figure out a case that would have three of these comorbidities altogether. These are the medications: carvedilol 12.5 twice a day, sacubitril valsartan 103/97 twice a day, spironolactone 25 daily, furosemide 60 milligrams daily, metformin 1000 twice daily, and apixaban 5 twice a day, along with rosuvastatin 40 milligrams daily. And I think we can all share in the frustration of trying to listen to your patients read to you medications by telephone, where it often sounds like this. And I play the game of how many letters do I need in order to know which medication they're talking about. The patient generally feels well, but is chronically limited at functional class 2 to 3. Blood pressure is reasonable at 132/72, heart rate 66 and regular. There's mild evidence of ongoing congestion. Again, not unusual for somebody being seen in clinic. The CBC and electrolytes were normal. They're, again, moderate renal insufficiency with creatinine 130 and a GFR of 41 without proteinuria and a hemoglobin A1C of 7.1%. The coexistence of diabetes and heart failure is extremely common, and this relates to the impact of diabetes both directly as a toxicity to the cardiomyocytes and the myocardium, as well as through its coexistence with hypertension and its impact on coronary artery disease. And all of this leads to a stiffened ventricle, in some cases systolic dysfunction, but almost always diastolic dysfunction. And I think all of our colleagues that see a lot of heart failure patients will say, as soon as the patient has diabetes, you often struggle with evidence of congestion. Also, diabetes has a major impact on kidney function, which itself can also worsen heart failure. And we know this from epidemiologic data that diabetes begets heart failure. And this is the picture from the United States of the incidence of diabetes across geographic areas. And you can see that it pretty much overlaps with where there is a rate of death from heart failure. And we, from a basic science and translational science perspective, we know that diabetes has a direct impact on diastolic function. So this is data looking at diastolic function, which essentially is a surrogate measure of congestion. And you can see here that as your diabetes advances to requiring insulin, measurements of diastolic function and diastolic dysfunction worsen. So over here, the E over E prime rate, which is an echocardiographic estimate of how congested a patient is, will increase with progression of diabetes. And this is shown in a different way. If you look at patients with diabetes on insulin and compared to somebody with pre-diabetes, the incidence of severe diastolic dysfunction is much higher. So in summary, diabetes is associated with development of congestion in those at risk, and this is presumably related either to direct myocardial toxicity or through its deleterious effects on renal function and coronary arteries and coronary artery disease. How important is congestion in heart failure? Well, it's really important. And it's probably one of the most important prognostic features, such that the more congested somebody is when they leave hospital, the more likely they are to die in the next 6 months. And when you combine signs of congestion with renal dysfunction, there is a synergistic effect such that those who have more than three or more signs of congestion and have significant renal dysfunction have a very high rate of death and adverse cardiac events. How common is ongoing congestion in ambulatory heart failure patients? Well, it kind of depends on how closely you look. And this is relatively contemporary data looking at about 350 patients coming to an ambulatory clinic. And I imagine these numbers would be even higher if you just looked at patients with diabetes and heart failure. But of the 342 patients, 250 of them had clinical or ultrasonographic evidence of congestion. And only 100 had no evidence of congestion. So diabetes can contribute to heart failure and worsening congestion. Congestion carries with its negative prognostic implications, and many ambulatory patients with heart failure, especially those with diabetes, are congested when they come to clinic. So what if there were a medication that treats both diabetes and also relieves congestion? Would that be impactful? And of course, as many of you are aware and has been discussed previously during this conference, we know that SGLT2 inhibitors are a potent medication in diabetes and help relieve congestion, and they do so in numerous ways, some of which are not completely understood. But with respect to its impact on diuretics and in comparison with diuretics, they have a more sustained natriuretic effect. They have an additive effect with loop diuretics. They don't activate renin, angiotensin, aldosterone, and sympathetic nervous activation like the loop diuretics do. And they reduce the amount of potassium magnesium that is wasted by the loop diuretics. And finally, they may impact on increasing uric acid secretion, which of course is important in trying to avoid things like gout. And because of this, we've learned that in fact the clinical effect of SGLT2 inhibitors is to reduce the incidence of diabetes, reduce the incidence of heart failure in those with diabetes. And this was first published in 2015. And subsequent to that, we have major trials that have looked at heart failure, reduced ejection fraction with or without diabetes, and the use of SGLT2 inhibitors, in this case, empagliflozin and dapagliflozin, and both have shown impressive results in reducing combined endpoints, but driven by reduction in heart failure admissions. And then finally, and most recently, just published a couple of months ago, was the EMPEROR PRESERVE trial looking at empagliflozin in heart failure, preserves ejection fraction, and again, showing a positive benefit in patients with heart failure with or without diabetes. And this was the most recent trial data showing improvement in major adverse cardiac events, again, driven by reduction in hospitalization for heart failure. The initiation of SGLT2 inhibitors in heart failure can be a little bit challenging. And this is a good schema to show how we kind of do this in clinic. But essentially, when I'm seeing a patient in clinic, I ask myself, is the patient still volume overloaded? And if they are, I'll often, and they're not on an SGLT2 inhibitor yet, I'll often add it. If they're euvolemic and normotensive or hypertensive, I may add it and then think about potentially reducing the diuretic. And of course, if they're volume contracted or hypotensive, then that's probably not the time to escalate diuretic therapy. So in going back to our case, given that the patient remained congested, you decide to add empagliflozin, and 1 month later, you see the patient in clinic, and the patient has improved functional capacity, feels better, is now NYHA class 2, but the creatinine has risen from 130 to 160 micromoles per liter. And so the question is what to do at this point. And at this point, I'll show you an article that was published on my birthday of this year, where a nephrologist and a cardiologist got into a heated debate over a medication that was stopped. I don't know how many of you saw this. This is from Ohio. I do not know either the medication or the nephrologist or the cardiologist. And I do not condone any violence when managing patients, but I found this quite interesting. And then, of course, the follow-up from the Twitterverse I found quite entertaining. This was a fight between a cardiologist and nephrologist over the fact that one of them discontinued medication on a patient. Anyone in medicine definitely knows what this medication was. And of course, the question becomes, how are you supposed to react to a rise in creatinine in somebody who you're decongesting? And we struggle with this a lot with our nephrology colleagues and lots of different physicians who are looking after our patients, because many of them have the comorbidities are outlined and have multiple different specialists, including their family physician. So this is a very interesting article just published within the year, looking at acute kidney function declines in the context of decongestion and acute decompensated heart failure. And what they showed was that it is true that if you looked at the decline in GFR alone by itself, when you interpret it by itself, certainly it has a negative prognostic implication with a positive hazard ratio. But when you look alone at markers of decongestion, these are actually protective. So the question is, what happens when you try to combine the two? And these authors showed quite elegantly was that in patients where they had evidence of decongestion, the impact of a reduction in GFR completely disappears. Whether you looked at a reduction in BNP or an increase in hematocrit, if you had objective evidence of decongestion, the fact that the GFR went down or the creatinine went up was no longer relevant. And I think the take-home message from this is, and of course, I acknowledge that this was an inpatient study with acute heart failure, but a lot, whether or not somebody's been admitted to hospital or you're decongesting them as an outpatient, it's a little bit arbitrary. And I think that the message certainly carries through to our ambulatory patients that if there's a rising creatinine, but also evidence of decongestion, that diuretics, be it loop, SGLT2, thiazide, they do not necessarily need to be reduced or discontinued. And as I tell the house staff that rotate through my clinic, that if you had a choice with your patient to optimize one single factor, improving functional capacity is singly the most important thing you can do, because functional capacity is by far the strongest prognostic factor in heart failure as well as many other diseases. So we'll quickly move to atrial fibrillation and heart failure. I think important points to be made about managing these patients is that we've learned from the clinical trials over the years that all patients with heart failure and atrial fibrillation need to be anticoagulated. There's no question about that. And that if you're going to use a DOAC, and many patients these days are on DOACs for atrial fibrillation and heart failure, that you need to pay special attention to renal function, because many of our patients with heart failure have chronic kidney disease. And this I thought was a useful table looking at dosages of DOACs with considering renal function. And you have to monitor renal function over time because it can change, as we mentioned, with the diuretic use. And the next question that comes up with atrial fibrillation is whether or not we should adopt a rate or rhythm control strategy for dealing with it. And we thought we'd answer this question with the AFFIRM trial in all patients with atrial fibrillation and the atrial fibrillation and heart failure trial from about 13 years ago, where basically there was no difference in rhythm versus rate control. And this was a graph. And up until about a year ago, this was the best data we had. There were several other studies that replicated this, that essentially an aggressive rhythm control strategy, unless patients remain symptomatic, in patients with heart failure was really not worth the trouble. And you ended up running into toxicities with medications. Most recently, a German group published the EAST atrial fibrillation trial, which was published about a year ago. And then just a couple of months ago, the subgroup analysis in patients with atrial fibrillation and heart failure came out, looking at rhythm versus rate control. And they actually showed benefit, and they showed a benefit in a combined endpoint. They combined death from cardiovascular cause, hospitalization for myocardial infarction or heart failure or stroke. And they showed that in all kinds of heart failure, be it all comers, heart failure with reduced, heart failure mid-range, or heart failure preserved, that there was some benefit. And of course, when you looked at what that strategy was in terms of rhythm control, it involved amiodarone primarily, especially in the heart failure reduced ejection fraction. They used a lot of flecainide, which we tend not to use as much in heart failure patients, but that was their local practice. And then they used ablation. And it's important to acknowledge that there was no protocolization of which strategy that they needed to use. And then, of course, the explanation for potentially why the strategy works now when it didn't work 13 years ago is there was an increased use in ablation. Which again was not common practice 13 years ago. It's important to acknowledge that the all-cause death was not different in either group, and that there was a substantial amount of issues with side effects from the antiarrhythmic therapy. So I think to summarize, the management of atrial fibrillation and heart failure, aside from making sure they're all anticoagulated and adjusting the DOACs, is that first of all, adequate decongestion actually also improves rate control. So if you have a congested patient, decongesting them will help with rate control. For rate control for patients with heart failure and reduced ejection fraction, beta blockers should be used as first line, and digoxin is a good second agent. And for patients with heart failure for preserved ejection fraction, either a beta blocker or a calcium channel blocker can be used for rate control. And rhythm control should be considered in all patients with heart failure and new atrial fibrillation, which is an important point. This trial only looked at patients, the most recent trial only looked at patients with new AFib, and the risks and benefits carefully discussed with patients. And if a rhythm control strategy is selected, it should consider the breadth of antiarrhythmic therapies along with their risks and benefits, both short-term and long-term. And I think with that, I'll stop there. Thank you.